Thank you for the introduction. My name is Hadházi, and the topic of this presentation is connected to an applied research project. So let's first overview the agenda of this presentation. First, I will speak about the motivation of our research, then the expectations and limitations of our solutions will be discussed. Then I will show some details of the designed and implemented methods, and finally I will take some conclusions. About the motivation, our research is done as an applied research in part of an applied research project which is granted by a Piaci Kft, or which is financed by the Piaci Kft grant. The purpose is development of tools for planning minimally invasive and robotic surgical interventions based on artificial intelligence and three-dimensional design. This work is done by a collaborating team. The team is led by the Gamma Digital Fejlesztő és Szolgáltató Kft. and 3 departments of the Budapest University of Technologies, Faculty of Electrical Engineering and Informatics was also a collaborator. Our work was the semiautomatic segmentation of the chest CT scans. So first speak about this kind of surgery operation. Minimally invasive chest lobectomy's goal is to remove pulmonary lung lobe, which contains nodules, tumors. During this operation, first the input ports and their locations are determined, then the necessary incisions in the skins, in the adipose tissues and in the pleura is done. After, the chest lobe to be removed is localized with the connected vessels and with the connected airways, the bronchial. Then this lobe is detached from these connected vessels and bronchial segments. Then it can be removed at one of the ports, which is opened in the body between 2 neighboring ribs. And after removing this lobe, the remaining lymph nodes can be examined and dissected if it's necessary. Then the final step is the closure of the incision. If we compare this kind of surgical operation to the classical open thoracotomy, we can say that the operating time and the recovery time of the patient is significantly shorter. It causes less strain on the patient. However, it costs more difficult to localize parts of the lungs, which is necessary to plan an adequate surgery operation. And this is the reason why 3-dimensional segmentation of the chest can be help and improve the quality of these medical operations by enable to planning the trajectory of the surgical equipments and instruments, and to enable to plan the concrete size, angle, and the entry ports and the trochat placed in the body. About the expectations of our solutions, we must segment almost every organs of the chest. We must discriminate skin tissues, adipose tissues, bones. We must segment and discriminate blood vessels into systemic aorta, pulmonary artery and vein tree. We must also segment lung parenchyma, bronchial tree, tumors, and also the diaphragm. The most difficulty is caused by that our inputs are computed tomography scans acquired in daily clinical routine. What does it mean? The slide spacing of these inputs are significantly larger than the slide spacing of high-resolution computed tomography scans, which are usually which can be usually found in large-scale data sets connected to similar problems. And also, this large size spacing causes the so-called partial volume artifact. Another problem is the intravenous contrast agent is administered in asynchronous way compared to the acquisition of the CT scan, which shows that these scans are not in early phase, not in late phase, and also significant metal artifact is visible in these CT reconstructions. And another problem is that these scans can come from a wide range of hospitals. This means that different reconstruction methods, different kernels are utilized during these scans, and these results that the contrast signal to noise ratio, contrast to noise ratio, and the quality of these scans vary in a wide range. About the limitations of our solutions. Our final goal is creating a commercially available system. Therefore, we must not violate license restrictions in our work. It's also required that we prove a solution which can be utilized during surgery operations. What does it mean? Our solution must be fine, and our solution must be robust enough that it can be utilized, for example, in the kind of robotic surgery. And another limitation is that our input scans come from wide range, and this also means that most of the training data sets which are available in this kind of problems cannot be used, unfortunately. About the main aspects of our implemented approaches, we utilized algorithmic image processing in every subproblem. In this kind of algorithms, we always tried to use shape and appearance models. And one of the most important facts of these algorithms is that we usually get tunable parameters to tune the trade-off between maximum a posteriori and maximum likelihood behavior of our algorithm. What does it mean? In order to get robust methods, we must use a priori models, which is closer to the Bayesian behavior. But in order to get fine segmentations, we must produce high-quality segmentations, which require mainly maximum likelihood methods. In many subtasks, we can combine algorithmic image processing and machine learning, typically in two scenarios. In the first, we used algorithmic image processing to detect regions of interest which are discriminated by machine learning to true positive and false positive ones, while in the second scenario, the machine learning is utilized to produce robust but rough segmentations of the organs, for example, of the sternum, which is refined by algorithmic image processing. About the utilized technologies, as I said, we use image processing machine learning and a lot of non-benchmark large-scale numerical optimization, which means that we must implement a lot of special version of these algorithms. And in order to constrain our computation times at predefined limits, we compute in graphics processor units. There are many fine details which can be discussed in this presentation, but in my opinion the time will not be enough to do this. So let me allow to only highlight some interesting aspects of our works and our subproblems. For example, in the case of lung parenchyma segmentations, we cannot find data sets which is segmented consistently. The reason of this is that segmenting the lungs in more than 200 or 300 facial slices, it's a very boring task, and there are very few radiologists who will make it in fine quality. So this is the reason, for example, why we used algorithmic image processing in this problem by utilizing an implicit shape prior. Another interesting part was the segmentation of the systemic blood parts or vessels of the chest. And two interesting subproblems is that we must segment the heart in a way that the cardiac adipose tissue must be segmented as part of the heart. There aren't any datasets which is labeled in this manner. This is the reason why we utilized dynamical programming and shape model to this problem. And another interesting part is that we must segment the diaphragm. The diaphragm is not visible typically in these low-resolution computed tomography scans, and in many parts of the chest we also cannot say that this is the bottom of the lung and this is the top of the liver, for example. We must interpolate between the segmented organs, and for example, this interpolation can be also done by algorithms instead of machine learning. The most difficult subproblem was the segmentation and discrimination of the pulmonary vessels to arterial and vein vessel tree. We make a lot of effort to this problem, and still yet we cannot find any good published method according to this subproblem. Finally, our recent solution utilizes machine learning to detect the entry points of the vessels and predict their types at the entry of the lung region or at the end of the hilar region, while in the lung the vessels can be traced also in this kind of low resolution computed tomography scans. This is the reason why we can utilize distance transform based iterative algorithmic segmentation and separation method. But we also prove manual correction abilities to the medical specialist, because we know that we cannot ever make a perfect solution for this problem. There will always be examples where we will fail. Another interesting thing that there are many datasets, for example, segmentation of the bronchial tree, but these datasets also contains high-resolution computed tomography scans, and the traceability of the bronchial tree in these scans are highly different than the traceability in classical 2.5 mm size thickness CT scans. This is the reason why we also make algorithmic image processing. And about the segmentation of the bones, here we combined machine learning and image processing, for example, in the kind of sternum segmentation by getting a rough but robust segmentation by machine learning and refining it by image processing algorithm, while in the segmentation of ribcage we designed and implemented algorithmic filtering which can detect primitives, region of interest of the ribs, which are classified by a so-called spin glass classification method to true and false region of interest, and the preserved true region of interest are utilized to interpolate the center line of these borders. By this interpolation we can also interpolate at the cartilage process, which is also a hard task, for example, also to radiologists. And to take some conclusions of our work, we make a difficult problem from many aspects. The first reason is that sufficient data sets are not available to most of our subproblems. Another reason is that the exact border and contour of the organs which would be segmented cannot defined consistently by radiologists. Another difficulty was the limit of the computation time. It was limited in 5 minutes for a CT scan. And what can be the main message of this presentation is that it's a trend nowadays that use machine learning to every problem and usually forget expert knowledge like image processing. But in practical problems, the available datasets and the cost of constructing sufficient dataset to a full end-to-end training is usually significantly higher than we can afford. And if we can use algorithmic image processing, we can make some kind of knowledge transform between machine learning and between expert knowledge, which should be used in every practical cases, in my opinion. Thank you for your kind attention.